So today we'll be discussing about the disorders or the diseases that is happening because of what is a wrong, or you can say like a defect of the metabolism. If there is defect in the carbohydrate metabolism, then these kind of disorders can occur. Okay. To be precise, we'll be discussing 4 cases today. Okay. What are the names of the cases? Let me write it down one by one. These are from the last class, yesterday, whatever class I have taken. There are 4 topics we will be discussing. First is G6PD deficiency disorder. Okay. First, try to understand what are the topics we will be covering today. First one is G6PD deficiency disorder. Second one is the von Gierke type 1 disorder. That is a glycogen storage disorder. Now, hereditary fructose intolerance is the third topic, and the fourth topic is the galactosemia. Among all of these 4, only one topic that you have little bit of idea, that is the galactosemia and galactosuria. Which gene is defective in galactosuria? I said which gene? GALT gene. And which enzyme? GAL1 PUT. What, anybody knows the full form of GAL? Galactose 1 uridyl transferase. Okay. Phosphoruridyl transferase. That is the enzyme which is defective. So among these 4 topics, one topic you have little bit of idea. Rest of the 3, I am just giving you first superficial idea what is this. G6PD, that is a Glucose-6-Phosphate Dehydrogenase. That is the enzyme which is deficient, and because of that some symptoms the body is producing. Okay, so from the name you can get that G6PD deficiency disorder. So this enzyme is deficient, because of that certain symptoms will get. Now where G6PD is important? In the HMP shunt pathway, right? So because of G6PD deficiency, certain enzymatic changes which was supposed to happen not happening, and because of that symptoms precipitating. Von Gierke type 1. What is glycogen? This is a type of glycogen storage disorder. What do you understand by the glycogen storage disorder? Our body
stores
glycogen. Whenever we are taking some food, some bit of glucose is circulating in the blood. Body is utilizing the glucose and taking energy out of it. And rest of the excess nutrient are getting converted into glycogen and then getting stored into the liver and in the muscles. And later on they are being used or utilized to get the energy. That is glycogen. That is the function of glycogen. Now glycogen storage disorder means the body is not being able to store it. Okay. So there are multiple types of glycogen storage disorder. For now I will tell you around 8 types. Okay. But we will be studying only one right now. The type 1. The type 1 is known as the von Gierke disorder. That is the glycogen storage disorder type 1. And there are 7 others. I will tell you just the names. Nothing more than that. Eventually, if we are getting more time, that time we will discuss about those. Okay, not today. Today we will be discussing only the type 1. Okay, and hereditary fructose intolerance. What do you understand by the word hereditary fructose intolerance? If it is hereditary, that means inherited. By birth you are getting. Fructose intolerance means body cannot utilize it. Whatever the reason is, body cannot utilize it. That is the basic funda. Okay, so 4 disorders, you got a little bit of idea what will happen in the disorders. Okay, let's see one by one. Okay, over here what we can see is a case. The case is what? A 23-year-old male patient presented with diffuse pain abdomen and vomiting for 2 days. Okay, and yellowish discoloration of urine, sclera and skin. So that something is suggestive toward jaundice. Okay, now acute breathlessness is there for 4 hours. Breathlessness means shortness of breath. Patient is not being able to breathe properly. Okay, and fever is there 101 degree Fahrenheit. So some infection is there or inflammation is there, because of that the patient is having fever. Fine. Pallor is there. Pallor means pale skin. Where do I see it mainly? In the conjunctiva. Which conjunctiva? Palpebral or bulbar? Lower palpebral conjunctiva. And in case of icterus, where do we see? Upper bulbar conjunctiva. Okay, fine. So we can see some pallor is there. So if the pallor is there, means low hemoglobin. The patient is having anemia, and because that the anemia is because of decreased hemoglobin. So patient is losing blood somewhere. That is why the hemoglobin is less. Right? So that is one thing that we are getting. Pallor is a keyword for us. And then we are getting moderate icterus. Icterus means jaundice. So jaundice means this blood which they are losing, that is getting broken down and forming more and more bilirubin. So that is why there was that yellowish discoloration of the urea and sclera, and we are getting the moderate icterus as well. Now high PR means pulse rate is high. Whenever the body is having some infection, okay, that time we can get high pulse rate. In medical terminology, physiologically we say tachycardia. Heart rate is low, less than 60 means bradycardia. More than 90 means tachycardia. Okay, so the patient is having tachycardia, and that is also related to the anemia and as well as the infection. Okay, if the body is having any sort of infection, we tend to have tachycardia. Okay, similarly, when there is anemia, that can also precipitate tachycardia. Okay, and respiratory rate is 28. Okay, fine. Cyanosis is there. Anybody have any idea what is cyanosis? Bluish discoloration. Why it happens? Low oxygenation. Yeah, low oxygen, and the hemoglobin is carrying more of carbon dioxide or carbon monoxide, HbCO. Okay, so that is why the patient is having cyanosis, or else the periphery is not getting proper oxygenation for whatever the reason is. If the hemoglobin is low, then the oxygen carrying capacity is also low. Okay, and that is why periphery are getting cyanosed. Okay, right? Okay, and decrease SpO2. SpO2 is the partial saturation, the oxygen saturation of the body. How we see the saturation? By we putting a probe in the fingers tips or in the ear lobes, and then we can see the what is the oxygen saturation in the body. Okay, if the patient is having SOV, means the oxygen saturation is also low. That is why the patient is having difficulty in breathing. The oxygenation is not proper to the tissues. Okay, now the patient started passing cola colored urine. That is, the patient is passing RBCs in the urine as well. Okay, so we got the source, some bit of the source that the patient is passing RBC in the urine. But there is one catch, that it is happening all of a sudden in a 23-year-old patient. Before that, everything was fine. He did not have any such thing. All of a sudden, patient is passing blood in the urine and all these symptoms precipitated. For all these kind of symptoms, the patient should have either prior history from the childhood the patient should have, or else if there is all of a sudden, then we say some trigger is there. Trigger means something is precipitating this thing. Before that, the patient was normal. Because of certain thing, the patient is precipitating this disease. Precipitating means patient was clinically normal before this infection or fever, whatever the cause of behind the fever is. As soon as the patient got the fever, this kind of symptoms started precipitating more. Okay. Now, this is in general we got from the history. Now we will see in the lab findings. In the lab findings, hemoglobin is 9.6. So we got hemoglobin is less. We were suspecting already. TLC count is 38,000. What is TLC count indicates? Total leukocyte count, not lymphocyte, leukocyte. Okay. So what does that indicate? TLC? Infection. If what is the normal range?
11,000.
Up to 11,000. From 4,000. Yeah, 4 to 11,000 is the normal range. Okay. So if it is less than 4,000, then also it is an infection. If it is more than 11,000, then also it is an infection. Which one is worse? Less than 4,000 or more than 11,000? Less than 4,000. Why? Leukocytes are what? Our immunity system. Whenever body is getting infection, the leukocytes are going there and fighting with the organisms and giving us the immunity. Now, if it is less than 4,000, means already the leukocytes are only less. So how will you fight? That is a neutropenic infection or neutropenic sepsis the patient might have developed. But if it is more than 11,000, means the body is having active infection, to fight which the body is producing more and more leukocyte and sending it to fight. So that is what is more means. That is also infection. Less means that will also indicate infection. But the more from as compared to the more one, if you are having the less amount of WBC counts, that is worst case. Okay. Now over here we are getting TLC count is 38,000, which is very, very high. Okay, more than 3 times of the normal. So that means patient is having severe infection, and because of that only this precipitated. Now, in case, do you think in case of viral infection the TLC count would have increased, or in case of bacterial infection the TLC count would have increased? Bacterial. Do we provide any antibiotic in case of viral infection? No. Why? Because antibiotic cannot kill virus. Your body immunity system will kill, or else the virus infection will subside on its own. Okay. Or antiviral drug you have to use. Okay. So whenever you are having some active infection, your TLC count increases if it is more of a bacterial infection. If it is a viral infection causes what? It decreases your immunity, and that time you can get a secondary bacterial infection. To cover that, we sometimes give antibiotic so that the secondary bacterial infection do not develop. That is a clinical thing. When you will go to medicine, that time you will understand what is secondary infection and what is opportunistic infection and all. These are separate things. Okay. So mostly if you are getting more TLC count, that is more going towards the bacterial infection only, more likely. Okay. Now direct bilirubin is, total bilirubin is given as 15.68. Normal is 0.8 to 1.2. So this is way more high. Okay. And the direct bilirubin is 3.24. Indirect is 12.44. What picture is it? hemolytic jaundice. That is why the indirect is more. Okay, fine. Now SGOT, SGPT, GGT all are raised. Okay. Now there is one thing that in case of dengue and in case of malaria also we can get this hemolytic picture. Blood can come out. So my first thought is, if it is an infection, patient is having fever and patient is losing blood in the urine, it could be dengue as well, it could be malaria as well. So they checked for it and they got negative. Dengue is also negative, malaria is also negative. So both these are ruled out. At least these two are not there. Then comes direct and indirect Coombs test. Why we are doing Coombs test? Basically to see if there is any RH incompetency is there or not. Okay, for now understand this much. Coombs test in detail you will learn in pathology as well as in microbiology. Okay, let's say you people might have heard about erythroblastosis fetalis in your physiology classes. So whenever the patient mother is having negative blood group and the fetus is having positive blood group, and if there is any rupture, any trauma or anything happening because of which the baby's blood is getting mixed with the maternal's blood, then in the next pregnancy the baby can get erythroblastosis fetalis. Why? The immune system is already sensitized to the positive blood and they will produce immunity. And as soon as the baby is again having positive blood, it is killing the fetus. Fine. So now how we can diagnose this? By taking the blood from the mother. If we are doing it, then it's a direct test. If we are taking from the fetus and then we are doing it, then it's an indirect test. Okay. By doing that, we can identify whether the patient is having blood is already sensitized with the Rh immunity or not. Okay. So that is in general Coombs test. Not necessary to know right now, but just so you know why is it being used. Okay, to see the Rh incompatibility is there or not. So that is also negative, means no Rh incompatibility, no history of blood transfusion, no Rh incompatibility, nothing as such is precipitating. So all of a sudden, because of the fever, if it is precipitating, it is more likely towards G6PD deficiency. G6PD deficiency is what is happening. This is Glucose-6-Phosphate Dehydrogenase. Okay, what it causes is it protects the RBC. The function of G6PD is it protects the RBC. How? Because whenever there is cellular metabolism is happening, there is some byproducts which is produced, that is known as the ROS, reactive oxygen species, which is toxic for our RBC. ROS, what it does, it destroys the RBC. Okay, ROS will just destroy the RBC, that is its function. But if you already have G6PD, the ROS will not be able to destroy the RBC. G6PD will protect you. Okay, in normal situation, whenever the patient is having G6PD deficiency, they are asymptomatic, means they don't present with the symptoms unless and until something is triggering it. Okay, you got it? Let's say I am having G6PD deficiency, but I will not present with the symptoms unless and until I am getting the trigger. My body is getting the trigger. In this case, the trigger is the infection. That severe infection, most likely viral or bacterial, any infection can cause the trigger. So here most likely it's a bacterial infection that is triggering the G6PD deficiency, and because of that trigger more and more amount of ROS is being produced and G6PD is not there to protect it, and RBCs are getting destroyed, and that is giving you a hemolytic jaundice-like picture. So till our last classes we were concerned about diagnosing hemolytic jaundice. Now our part is to understand why the hemolytic jaundice is happening. This is just an example of hemolytic jaundice. There are many reasons to develop a hemolytic jaundice. So in G6PD deficiency, why is it happening? Because it is protecting the RBC from reactive oxygen species, ROS. Now the ROS is getting produced more and more in a stressful condition, in infection. There are many other reasons, like some chemicals are like naphthalene can cause, some food dietary, like in Southern Africa there are some beans called fava beans. Okay, if you ingest fava beans and somebody is having this G6PD deficiency, then the case will precipitate more. Even till now the patient was asymptomatic. After ingestion of fava beans, the symptoms will start developing. Patient will have losing blood, bleeding will start from multiple places. Okay, and they will have a picture like hemolytic jaundice. So, and there are some drugs as well, like you must have heard about these painkillers that we normally use. Those are in pharmacology you will remember as non-steroidal anti-inflammatory drugs, NSAIDs. Okay, like paracetamol, ibuprofen, these are the drugs. Okay, if somebody is having this disorder which is not symptomatic yet, but you are giving some large dose of paracetamol, ibuprofen, that can precipitate. Not all the time, but can precipitate. But there is one group of drug, one anti-malarial drug is there that particularly precipitates this disorder. Okay, I'll tell you later. That is why it's coming, how is it coming, I'll let you know everything. Okay, now for now, our diagnosis, it's a case of G6PD deficiency and with a hemolytic jaundice. Okay, fine. Now, What is your diagnosis and why? Your diagnosis, because the blood picture is showing you hemolytic jaundice, and there is no other reason like dengue or malaria. There is the Coombs test is also negative, so there is no other reason. All of a sudden the patient is having hemolytic jaundice like picture, and the precipitating cause might be some bacterial infection, and because of that you are getting this. Okay, so G6PD deficiency with a hemolytic jaundice like picture, that is your diagnosis. And why? You already got the blood picture and the clinical symptoms. Okay, now what is the cause of the disease? Most likely in this case the cause of the disease is a bacterial infection. However, you are coming to the conclusion the TLC count is 38,000, and because of that, whenever a person is having infection localized to a particular region, let's say you are having a lung infection, we will tell it as a lower respiratory tract infection, okay, or pneumonia. Okay, but whenever this infection is spreading to the all of the body through the bloodstream, first infection was localized to the lung only, we were calling it pneumonia. Later on, this infection spread all over the body, and that time we can call it as a sepsis. So this kind of counts you can get whenever the patient is having sepsis, means in general whole body is having the infection, and now if you don't control the infection, it will have its severe effects. Okay, not going in detail into what can be the complications of the sepsis. Okay. Now, what are the triggers for the disease? I already told you the triggers. It could be some chemicals like naphthalene, it could be fava beans, it could be some drugs that we are using like paracetamol, ibuprofen like NSAIDs. It can be some antimalarial drug as well. The name of the drug is primaquine. Okay, why we are using primaquine? Whenever patient is coming with malaria, we are giving them primaquine so that this malaria do not relapse. Relapse means फिर से दोबारा ना हो जाए. Because this malaria parasite, if this is remaining in the circulation, they can again cause another episode of malaria. Initially the patient will be asymptomatic and you will feel like, okay, the patient is fine, now discharge the patient. But some bit of the parasites are remaining, and later on they can reappear in the circulation and cause another episode. So just to avoid, and those remaining ones, those are those parasites which is there in your body, stored in your body, like there are multiple forms. When you will go to microbiology, you'll know merozoite, sporozoite, trophozoite, which form is there, which form is remaining in the body. So to kill those remnants, that is also known as the hypnozoites. Okay, they are sleeping, that is why hypno. Okay, they are sleeping state. Later on they get activated and cause the disease. So to kill those, we are using primaquine. Okay, so that can also cause the disease. Okay, these are the triggers. And over here, and viral and bacterial infection, that can also cause. And over here, most likely the cause is a bacterial infection. Done. Now, what is the inheritance of the disease? Inheritance of the disease means the gene have to be defective, then only you will get the disease. How is it happening? Let's say the father is having this gene, okay, X and Y. The father is having XY and the mother is having XX in general. Let me give you a better picture over here. Let's say there is a father and there is a mother. Okay. Now mother's chromosomes are XX chromosome, we all know, and father's chromosome is XY. Okay. Let's say the mother is having one gene which is defective, XC. XC is the defective gene. Okay. If this is the case, how many possibilities are there? Okay. One is this, one is this, one is this, another one is this, right? These are four possibilities. What can come? XX, which is a normal, then X and Y, that is also a normal, then XC and Y, right? And then, sorry, XC and X, and then XC and Y. Now, this is a normal female child, okay? This is a normal male child. Got it? Now this one is what? Carrier. Female who is a carrier. Okay? And this is a male who is diseased. Why? Because there is only one X chromosome. It's a X chromosome linked disorder. Okay? And it's a recessive disorder. If both the X chromosomes are defective, then only the patient will be diseased. And if there is only one X chromosome, then this patient will be diseased only. That is how the inheritance comes. Okay? Fine. Now, if you see one thing, females can be carriers. Male can never be carriers because they have only one X chromosome. Whether they are getting it from, and most of the time, all the time it will be from the mother only. Because the Y chromosome they are getting from the father, that's why they are males. Okay. So if they are getting the defective gene from the mother, they will be diseased. If they are not getting the defective gene from the mother, they will be normal. So males can be normal or diseased. Females can be normal, carriers or diseased. Okay, so carriers can only be females, not males. Okay, got it? That is the inheritance, like how it is happening. Either mother is having defective gene or the father is having defective gene. You cannot conclude who is having defective gene, because if any one of is having the defective gene, these are the permutation combination. Depending upon the permutation combination, the boy can be carrier, or boy can be diseased or normal, and the girl can be carrier, normal or diseased. Okay, fine. Now, what is the function of the G6PD enzyme? To protect the RBC from ROS, reactive oxygen species. ROS is a metabolite which is created because of cellular metabolism. Now, there is one question. G6PD deficient patient gets protection against which parasite borne infection?
Malaria.
Malaria. Did you study anywhere?
Yes.
Yeah, tell.
In class 12.
Okay. In G6PD deficient patient, very good. In G6PD deficient patient, what happens? It's a, you can say it's a inert property. It's an inert property that the patient gets immunity from the malaria. They don't get malaria. The exact reason I also don't know. In the books also, if you find something, there are some books in higher research level, they are saying that repeating of gene repetition is one of the suspected cause, but the exact cause nobody could found it. Okay, so we are catching it like an inert property, like whoever is having G6PD deficiency, they will never get malaria. Okay, now how it can help you in clinically? Let's say somebody is coming to you with this kind of picture, fever and all this feature like a malaria. Okay, and you are suspecting like probably the patient is having malaria only, and before your result is coming, you have given the medicine, the primaquine, or else along with some other antibiotic, you have given primaquine. Now the patient was not having malaria, but because of your primaquine, the condition of the patient will even deteriorate further. Okay, because of certain infection, the patient was having this G6PD deficiency, which got precipitated, and moreover, you gave primaquine. So, whenever a patient is coming with similar kind of picture, first rule out whether it's malaria or not. If not malaria, then no need of giving primaquine. You can use other antibiotics as well. There are many antibiotics you can treat with. No need of giving this primaquine. So, that is how you have to rule out that it is not malaria. First, you have to rule out it is malaria or not. If it is not malaria, you cannot give. And more importantly, the patient can never have malaria. Okay. Last question is, which anti-malarial agent precipitates the hemolytic anemia in G6PD deficient patient? Primaquine. That I have already said. Okay. So, these are the questions. I'll give you time so that you can click the cases and the questions. Okay. Answers, you have to write it on your own. Okay. Right now, I am discussing the answers. Listen to it, understand it. If you are having doubts, ask me. I'll again tell the answers, but I will not provide you the written prepared answers. Okay? You have to prepare your answers. If you find any difficulties after going to your room, if you find any difficulties to write or prepare the answers, come and ask us. We'll help you at that time. But answers should be prepared by yourself. Okay? In that way, you will understand the better why you are making the answer, why you are writing these answers. Okay? Till now, everyone is fine. Any difficulties? Any doubts? Okay. Okay. So our next topic is von Gierke. So we are done with the G6PD. Now von Gierke disorder. Now what happens is, it's a glycogen storage disorder. I already told you glycogen storage disorder, what will happen? The body will not be able to store the glycogen. So that is why they are presenting with certain symptoms. Now let us see the symptoms. Now before I start, I will like to tell you that these two diseases, hereditary fructose intolerance, von Gierke, these will mostly have similar kind of presentation. Okay, similar kind of presentation you will get. Okay, but there is some minor changes. The symptoms are similar, the presentation is similar, but there will be some catch words that you have to catch hold on to so that you can understand. Okay, fine. Now let us see the case. A young boy presents in the emergency in unresponsive state. Okay, and frothing is coming from the mouth. So patient is unresponsive, patient is not responding, and there is frothing from the mouth. On examination, you found the GRBS, means blood glucose level. The blood glucose level is 30. Normal blood glucose level should be
90.
80 to 110, 120 you can catch. That is the normal range. Okay, if it is in between that, then it is a normal blood sugar. So is it normal? No, the patient is having hypoglycemia. The blood sugar level is less. So something or other is happening in the body, that is why the blood sugar level is low. So we have to find it out. Now after giving dextrose correction, you have given dextrose correction, IV dextrose दे दिया. After giving dextrose correction, the patient become conscious and oriented. Now the patient is fine. Okay, because the blood sugar level has raised by giving dextrose correction. Now, on further examination, there was hepatomegaly. Now, you saw that the patient is having enlarged liver as well. So, something is again wrong with the liver, something is wrong with the glucose. That is why there is hypoglycemia as well as hepatomegaly. Okay. Now, you have done some lab findings. In the lab findings, what you got? The serum lactate level is high. Okay. Serum lactate level is high means lactic acid is producing more. Lactic acidosis is happening in the patient. You have to find the cause of it as well. And serum uric acid is also high and blood glucose low, you already know. Diagnosis is given as the von Gierke disorder, glycogen storage disorder. Now, why? Whenever we are having this glycogen storage disorder, means glycogen is not there. So, the circulating blood glucose, whichever is there in your body, that is getting metabolized and giving you energy. As soon as the circulating glucose is over, our body tends to bring the stores from the stores. That is glycogenolysis should happen. The glycogen will break down, will give us the energy that is required. Whenever body requires energy, body is bringing that glycogen from the liver, breaking the glycogen and then forming the energy from there. Fine. So, in this patient, the patient is not having glycogen because of the storage disorder. So, that is why the patient's blood sugar is falling down. Okay. As soon as you are giving the dextrose correction or you are letting the patient feed. Right now, in this patient, the patient was already frothing and unconscious. So, you cannot feed him anything or her anything right now at this situation. So, we had to give IV injection. But if the patient was being able to have something, initially in case of hypoglycemia, what will happen if the patient will sweat more, patient will have reeling of head, blackout can happen. Okay. And in that case, immediately you have to give them glucose, or the glucose powder or anything to eat. Okay, sugar दे दो, glucose दे दो, fruits दे दो, कुछ ना कुछ दे दो ताकि वो खा के, so that the glucose level comes back to normal. Whenever the glucose level comes back to normal, the patient feels better. So one catch point in case of glycogen storage disorder is there will be recurrent hypoglycemia. As soon as the circulating glucose is getting over, you will have hypoglycemic episode. Okay, so that is one catch point, that is there will be a recurrent hypoglycemia. As soon as the patient is taking food or taking meal, it is fine. Again having hypoglycemia. Again taking food, again it is fine. So that is a catch point that you have to see, that recurrent hypoglycemic episode will be there. Fine. So remember this thing. Now, why this uric acid is increasing and lactate level is increasing? Let's say you don't have glycogen in your body and body needs energy. So how will it get the energy? It will try to break down the glucose which is circulating, if there is any glucose. So it will try to go for glycolysis. But already the body is deficient with oxygen and all. So in low oxygen condition, if the body is trying to break down the glucose, it will cause in formation of lactic acidosis. In the anaerobic condition, if you are trying for more glycolysis, it will form more and more amount of lactic acid. That is from where you are getting the lactic acids. Okay. And serum urea you are getting from the byproducts of the metabolism. Okay. That's all. Now in case of von Gierke disorder, there are certain questions. What is the diagnosis and explain why? Diagnosis is von Gierke type 1. Now among the von Gierke there is two types, two subtypes. Okay, to be precise, let's say this is von Gierke's disorder. There are two subtypes. One is, it is already type 1, you know. So this is type 1A and 1B. Type 1A and type 1B. In case of type 1A, the presentation will be same like this. Okay, the case that I am showing, the same kind of presentation will be in case of type 1A. So if somebody is asking the exact diagnosis of this case, it will be von Gierke's disorder type 1A. In case of type 1B, what is happening? In case of type 1B, the patient is having neutropenia. Neutropenia is what? The WBC counts are less than 4000. Okay. Now, if you notice that this is a congenital disorder, right? So by birth, the patient is having this defect. Now, whenever the child is taking birth and he or she is having neutropenia, means the child is already prone to infection because they don't have any immunity. Whatever immunity they are getting from the mother by inherited immunity, that is all. Okay. And other than that, they don't have any immunity. They are not vaccinated. They are not getting in any herd immunity, nothing. So they are already prone to more kind of infections. And more importantly, the baby is having neutropenia. So they are more tend to develop sepsis and patient can die as well in case of type 1B. So if similar kind of presentation is given along with mentioning that neutropenia is there, patient is having infection, and patient died, or any history that the patient is admitted in ICU, neonatal ICU, and patient is requiring multiple antibiotic coverage and all these kind of presentation is given in the history, that is going towards von Gierke type 1b. Okay, fine. Now, why the explanation? The key words are the patient will have recurrent hypoglycemia. Okay, how you can come to the conclusion it's a von Gierke? Recurrent hypoglycemia will be there. Okay, if it is not recurrent, then it is less likely von Gierke. It could be something else. But if it is von Gierke, there will be history of similar episodes before as well. And those times patient was getting or eating something and patient was feeling better. This time why patient came? Because patient was not in the condition to eat anything. Patient was feeling like that and immediately patient collapsed. Okay. Now hypoglycemia, there will be hyperuricemia. Hyperuricemia means break the word. Hyper means more. Uric means uric acid, and emia means in the blood circulation. In the blood circulation, the uric acid level is more than the normal level. That is hyperuricemia. The patient can have lactic acidosis. What we got? The lactate level was, serum lactate level was high. And why the lactic acidosis is happening? Because of in the anaerobic condition, more and more amount of glycolysis is happening to produce the energy to get the ATP. Okay, and that is why the lactic acidosis is happening. Okay, got it. Fine. Now that is why your diagnosis is von Gierke's disorder along with the clinical features. Got it? Keyword recurrent hypoglycemia. Okay. How many types of von Gierke disorder are there? Two types. Type 1A, type 1B. Make sure you focus on the question if they are asking how many types of glycogen storage disorders are there and how many types of von Gierke's disorders are there. If they are asking about von Gierke's disorder, it's 2 types. If they are asking about glycogen storage disorder, there are 8 types. Okay, fine. Now, what is the enzyme which is deficient in this disease? The enzyme, that is, the last one was glucose-6-Phosphate Dehydrogenase, right? Over here it is glucose-6-phosphatase. In short, we write it G6PASE, G6-PASE. Okay, why? Glucose-6-phosphatase. Okay, so that is the enzyme which is defective. Because of that, the patient is getting the von Gierke's disorder. Okay, if this enzyme is there, then it would have been normal. Okay, now because of absence of this enzyme, the byproduct which is there, the step which is not carrying forward, that metabolites is getting stored in the liver. Okay, because liver should have stored glycogen, and from there it should have broken down to glucose by glucose-6-phosphatase and would have produced ATP. Because of this defect of this enzyme, the steps is not getting completed. So the metabolite which should have broken down, that is not getting broken down, and that is getting stored in the liver, and that is producing the hepatomegaly as well. Okay, that is the cause behind the hepatomegaly. So these are the causes behind the symptoms. Now, what are the types of the glycogen storage disorder? There are 8 types of glycogen storage disorder. Type 1 is the von Gierke. There is a easy mnemonic so that you can remember. That is वो physics, chemistry और मैथ्स में होशियार थे. Okay, easy to remember this mnemonic, right? Now from V it is von Gierke. Okay, from P it is Pompe. This is type 2. Okay, this is the sequence. Von Gierke is type 1, Pompe is type 2. From C there is Coris. Okay, that is type 3. From A it is Anderson's. This is type 4. From maths में this is McArdle. This is type 5. होशियार H is HERS, hers. Okay, this is type 6. And T से है Tauri, TAURI, that is type 7. Okay, no need to face so much of difficulty. Over here it is written. Okay, type 1 is von Gierke, type 2 is Pompe, type 3 is Cody, type 4 is Anderson, type 5 is McArdle, type 6 is hers, and type 7 is Tauris. The mnemonic is वो physics, chemistry और maths में होशियार थे. Okay, so this is an easy way to remember, because each of this disease having one enzyme which is defective, and because of that defect they cannot store the glycogen. In case of von Gierke, the enzyme is glucose-6-phosphatase. Okay, types of von Gierke, 2 types. type 1A, type 1B. Discussed about 1A, 1B. Now there is special type, that is type 0. Okay, we have said type 1 to type 7 and another remaining is type 0. In type 0, the enzyme is glycogen synthase. What do you understand by synthase? That is synthesis, that is forming. Now the enzyme glycogen synthase is forming the glycogen from the routine glucose which is circulating in our body. So glycogen storage should be done by this enzyme only. So if the synthesis is only not there, then obviously the glycogen will not get stored. Understood? In other ones, glycogen is getting stored but cannot utilize it. Okay, over here the glycogen formation is only not happening because the synthase enzyme is only not there. Got it? So that this condition can also precipitate with a repeated episodes of hypoglycemia. Less likely to ask you people in the clinics, but yeah, glycogen synthase will also present like a repeated history of hypoglycemia. Why? Because the glycogen is not getting stored. The amount of time you are having circulating glucose, you are getting the energy from it. As soon as the circulating glucose is getting over, your energy source is also over. Got it? Okay. Now, what is type 0 glycogen storage disorder and which enzyme is deficient? Yeah, I told already. Type 0 is when there is defect of the glycogen synthase enzyme and because of that the glycogen is not forming only. बाकी में स्टोर नहीं हो रहा है, इसमें फॉर्म ही नहीं हो रहा है. ठीक है? Okay. Any doubts from the topic? What is the keyword from this topic? Recurrent hypoglycemia. Because the symptoms that I have wrote right now, you will find out the same symptoms in the next cases as well. What is the next case? Hereditary fructose intolerance. From which type of food you get more amount of fructose? Fruits. Mostly from the fruits we are getting more amount of fructose. Okay. So let's see our case. What is there in the case? A 3-year-old boy is brought in an unconscious state. Again unconscious. Okay. Just see the similarities of the cases. He had headache, dizziness and a history of intake of sugarcane juice. Now there is a history of sugarcane juice intake. Now the patient was unconscious, patient was feeling weak and patient took sugarcane juice. So the patient's condition should have improved as per our last case. Just because the patient was not frothing from mouth, he just became unconscious and as soon as he came to consciousness, he took sugarcane juice. Right now his sugar should have been normal because he took some sugarcane juice, but what is happening? The patient still followed by weakness only. There is no improvement of the patient's condition, whereas it should have improved because sugarcane contains lots and lots quantity of fructose, maltose and other sugar components. Okay. Now on examination you are getting hepatomegaly again. See again over here also hepatomegaly is there. Baby was icteric. Okay, because of the hepatomegaly the patient is having jaundice. Knee joint tenderness. Now over here there is one different symptom, knee joint tenderness. That could have been there as well. It is here. In that condition you did not get knee joint tenderness. Why knee joint tenderness? What I told is uricemia, uric acid. If we are having more amount of uric acid in our blood circulation, that can go to the joint spaces and deposit over there. These are uric acid crystals basically. When they are getting deposited in the joint space, they can result in gouty arthritis that we say. Most common area to get gout is the which toe? Great toe. What is the joint? Specific joint? Metatarsophalangeal joint. Metatarsophalangeal joint. Your foot is over, right, in anatomy. So metatarsophalangeal joint. That is the most common location to get a gout. Okay. Now over there, the uric acid crystals are getting deposited, and they can get deposited in any other joint as well. That is the first symptom that according to our history. Not everybody will present like that, but yeah, that is where it gets precipitated first. Now in this patient, it is getting deposited in the knee joint. That is why the patient is having knee joint tenderness. Okay. And following are the lab findings. See, blood glucose is 40 over here. Again the blood glucose is low. See the similarity. Uric acid is 7.9. Uric acid is again high over here. Blood lactate level is also high. Okay. And urea and creatinine is also high. Urea creatinine high means it is indicating something is wrong with the kidney. Okay. So not necessarily all the patient will present like a kidney failure picture, but yeah, they can have some kidney symptoms because of hyperuricemia and because of the other metabolites which is causing more pressure on the kidney. The kidney can precipitate like that. Okay, fine. Because of dehydration also the urea creatinine can rise. Okay, so not everybody will present like this, but the good clinical symptoms are lactic acid is high, uric acid is high, blood glucose level is low. Exact same presentation. But over here, after giving the sugarcane juice, the patient did not improve. Okay, over there it improved. Over there was a recurrent episode. Over here it's a single episode. Okay, if you give other than sugarcane juice something else which is not containing more of fructose but more of glucose or some other sucrose, maltose, something like that, then the patient might have improved. They might have felt better. Okay, why? In this patient, why we are discussing is after giving sugarcane also it is not improving, means the patient is having fructose intolerance. You are giving fructose, but the patient cannot utilize it. Why? In your theory classes, it has been taught to you how the fructose is getting metabolized. So we have to go to fructose metabolism steps. Now your question, why hepatomegaly was there? Try to see over here. Now the fructose is getting broken down into fructose 1-phosphate by the enzyme fructokinase. Okay. And now from fructose 1-phosphate aldolase B. This is the main enzyme. There are 3 types of aldolases. Aldolase A is there, B is there, C is there. But for us, the main important enzyme is the aldolase B, which is breaking down the fructose 1-phosphate into glyceraldehyde and dihydroxyacetone phosphate. Okay. From there, it is getting metabolized in its own path. That has been taught to you in your theory classes. Now, because of this deficiency of this enzyme aldolase B, what is happening from fructose 1-phosphate? These steps is not happening. Try to understand here. Over there, instead of aldolase B, there was glucose-6-phosphatase. Okay, because of this, that step was not continuing. What will happen? This byproduct will be more and more in amount. Okay, if you are giving fructose is getting converted into fructose 1-phosphate, but after that there is no progression. And this fructose 1-phosphate is getting accumulated in the liver, causing hepatomegaly. In that case also, because of 6-phosphatase, glucose-6-phosphatase, that byproduct is getting stored in the liver, causing hepatomegaly. That is why these all have similar kind of presentation. When fructose is not metabolizing the fructose 1-phosphate, body tries to get energy. Body needs energy. And why it is losing energy? Because from fructose to fructose 1-phosphate, ATP is getting used up and forming ADP. Okay. Whereas this metabolism would have produced more ATP for you. Rather than that, this step is taking up energy and not producing anything for you. So body is going into energy crisis. So body needs urgent energy to continue its processes. What it does, it goes for glycolysis. Whatever glycogen storage, whatever glucose it is getting, it's going to break it down. And in this process, the body is having low oxygen level. And in anaerobic condition, if you are going for high excessive amount of glycolysis, it will produce lactic acid. This is also known as a crab tree effect. Okay, that is how the lactic acids are producing more and more in our body. And that is why in all of these cases, you will get lactic acidosis. Got it? Okay. And hypoglycemia. Why hypoglycemia? Because if you are giving the fructose and it is not getting metabolized, obviously hypoglycemia will be there because you are not getting the source of energy only. Okay, it is not getting metabolized, you are getting hypoglycemia. That's all. Lactic acidosis is done. Hyperuricemia. One process is because of this lactic acid metabolism process, you can get as a byproduct, which is a minor source of uric acid. Another metabolism is the purine biosynthesis. Okay, whenever your purine pyrimidine metabolism will be over, that time you will understand better. But there is an enzyme which is PRPP synthetase enzyme. Okay, because of this enzyme defect, what is happening? The purine based nucleotide metabolism is defective, and that is causing more and more amount of uric acid. That is causing the hyperuricemia. That is the main cause of hyperuricemia. And the secondary cause is the lactic acidosis metabolism, from where you are getting a little bit more of uric acid, which is circulating more, getting deposited in the joints and presenting like a gout. Okay. So symptoms are same. The catchy points are, in case of von Gierke, there will be repeated hypoglycemia. In case of fructosuria, this will not be repeated. If you are giving other than fructose something else, the patient will improve immediately. That will get metabolized, the patient will improve. But if you are giving something, some fruit related things, sugarcane juice and all, and then the patient will not improve, because these are not getting metabolized. So these are two basic differences how to identify the case, because if you see the symptoms, the patient will find like same only, same to same but different. Okay, same but different. Okay, understood. Who is seeing too much of memes? Okay, now there is one more related topic, that is benign fructosuria. Okay, now we were talking about aldolase B because of which this disease is happening. Over here, if you see this flow chart, I have written that if there is aldolase B deficiency, we are getting HFI. HFI means hereditary fructose intolerance. Now there is another condition where this fructokinase is defective. You don't have the fructokinase only. So if you don't have the fructokinase, do you think that fructose to fructose 1-phosphate will happen? It will not happen. So there will not be accumulation of fructose 1-phosphate. So there is no hepatomegaly, no hyperuricemia, nothing. Kuch nahi hoga. Fine. The patient will not have hypoglycemia, nothing. The patients are completely asymptomatic. But there is a catch. Whenever you are doing the Benedict test, the Benedict test coming positive. Okay. Why? This fructose which is not getting metabolized, this will come out in the urine as it is. Got it? So that is known as the benign fructosuria. By the term benign in medical field, we say it's a mild form of disease. Okay. In this benign fructosuria, you don't have to treat the patient, you don't have to do anything. Just tell the patient to take fruits less and more of other items, because whatever fruits he is taking from the fruits, he is not the fructose that he is getting, that is not getting metabolized properly. The other nutrients he can get from the fruits, but not the fructose. Got it? And the fructose is getting out in the urine. At maximum point, what he can get is, he can get some urinary tract infection. Why? If the fructose are more in urine, that will lead to the growth of the organisms. The microorganisms can grow more in his urine sample. So at max, he can get a urinary tract infection. Okay, nothing more than that, and no other symptoms of any like hepatomegaly, hyperuricemia, all these symptoms, whatever was there, these will not be there at least, and the patient is completely fine. Probably some one of us might have benign fructosuria as well, but we will not get to know until and unless we are checking the urine samples. Okay, so when we are checking the urine samples, then only we can come to know, oh, okay, I have some reducing sugar is coming. Whether when you are checking the urine sample also, let's say you are doing a Benedict test only, you can identify some reducing sugar is there, but you cannot identify which reducing sugar is there. Then you do the paper chromatography, and then you can understand, oh, probably fructose is coming out. That means I am having benign fructosuria. Because of this defect in this enzyme, fructokinase, which is not there in my body, fructose is not getting metabolized. Okay, so comparison of HFI and benign fructosuria is also fine, right? Any doubts in this?
So the patient will be fructose deficient all his life?
Yeah, it will never get metabolized because the enzyme is only not there in the patient's body. If the enzyme is not there, it cannot break down to further steps. Okay, so that is how it will be. Whatever fructose he is taking, it will come out unchanged in his urine. Fine. But no symptoms, no precipitation of the disease. Got it? Let's see what are the questions given over here. What is the most probable diagnosis and explain why? Most probable diagnosis, most likely hereditary fructose intolerance. Why? Why it is not fructosuria, benign fructosuria? Because the patient is having symptoms. In benign fructosuria, you will never get any symptoms. Okay? So that is why it's a hereditary fructose intolerance, and explain why the same symptoms. The lactic acidosis is there, hyperuricemia is there, hypoglycemia is there, but it is not recurrent. That is the main difference between these two diagnoses. Okay, now what is the cause of the disease? Because of the defect in the aldolase B enzyme. Now this aldolase B enzyme is defective because of some genetic disorder. Okay, because of some genetic disorder only this aldolase B is not normal. So the chromosome which is responsible for this is chromosome number 9q22.3. In this location there is an aldolase B enzyme defective. Now do you understand by 9q22.3? Nothing, right? Okay. This is a normal structure of chromosome. We have read in our 11-12 studies, this is how a normal chromosome looks like. And this is a long arm. This is a short arm. The long arm is presented as P arm, and the short arm is presented as Q arm. Let's say this is the 9th chromosome. Okay? 9th chromosome in the short arm, 22. These are multiple segments that the scientists break down for better understanding, for their focusing which is the exact point where is the defect. So there are some multiple fractions. Let's say over here there is a 22.3 fraction which is defective. So 9th chromosome, short arm 22.3 fragment. Over here there is a defect. Because of this defect, this aldolase B is not there. And the defect is what type of defect? That is a missense mutation. Okay. In your biochemistry, when you will be studying, there are genetics basically when you will be studying. There are three types of, three important mutations that you should know. One is stop codon, another one is missense mutation, another one is a nonsense mutation. Okay. Over here, missense mutation is happening. I am not going into detail what is stop codon, what is missense mutation, nonsense mutation, because when things will come, take it gradually. अभी आधा खा के रखने का कोई ज़रूरत नहीं है. For now, just try to understand that missense mutation is happening at 22.3 locus in the short arm of the 9th chromosome. That is, in short, we write it like a 9q22.3 chromosome. And because of this mutation, we are getting the aldolase B. What is happening in case of missense mutation? Let's say this is a DNA double helix structure. Right? We know this is a DNA double helix structure. This is how the purine pyrimidine bonds are there. This is how the purine pyrimidines. What is the bonding? With A, T and G के साथ C है. Like T, A, C, G, A, T, G, C, G, C, T, A. Like this. It keeps on going. Now let's say in the 22.3 locus, this G gets converted into C. That is the missense mutation which is happening, and because of that all this sequence is following one after another. Got it? So this mutation in this locus in the short arm of the 9th chromosome leading to defect of the aldolase B enzyme. Because of this aldolase B enzyme, that fructose 1-phosphate is not getting converted into further steps, and fructose 1-phosphate is getting accumulated in the liver, leading to hepatomegaly, hyperuricemia because of purine, this metabolism disorder. Along with that, what is happening? Lactic acidosis is happening because of glycolysis in an anaerobic condition. So that is what is missense mutation. Okay, got it? Now what is the inheritance of the disease? The same thing. This is how it is happening. Now, unlike the last disorder in G6PD deficiency, what was happening? The males were diseased or normal, females were carriers. In this condition, it is equally distributed among males and females. There is no partiality. Okay, this is equally distributed and it precipitates when you are getting fruits or some foods which is containing more amount of fructose. Then only it precipitates, the symptom precipitates. Otherwise, symptom will not precipitate. Okay. Now, what are the biochemical basis of the signs and symptoms? Biochemical basis means they are trying to ask you if I am mentioning hepatomegaly. Okay, hepatomegaly. These are the symptoms that you are getting, right? Hepatomegaly is there. Then uricemia, uricemia is there. Lactic acidosis is there. Lactic acidosis is there, and hypoglycemia is there. Okay, these are the features that you are getting. Now, the reason behind it, that is what they are trying to ask you. What is the biochemical basis of the signs and the symptoms? What is the reason behind hepatomegaly? Hepatomegaly, accumulation of the fructose 1-phosphate in the liver. What is the reason of hyperuricemia? Because of the purine metabolism defect. Purine metabolism defect by as much as max they can ask you which enzyme is defective. That is the PRPP synthesis enzyme is defective. Because of that, hyperuricemia can occur. Lactic acidosis, why is it happening? In anaerobic condition, when the oxygen concentration is low, the body is trying to do glycolysis more and more, and because of that the patient is developing lactic acid, and which is causing the lactic acidosis. Fine. Why hypoglycemia? The body cannot utilize the fructose only, so obviously body is having low blood glucose, and that is causing the hypoglycemia. So the reason behind all these symptoms, done. What are the clinical manifestations and the laboratory findings? Same as whatever is given in the question. These clinical features and the lab findings are the uric acid is more, lactic level is more, blood glucose level is low, and in the particular case, the kidney picture is also there. That is why it's most likely acute kidney injury type. Okay, because it is not more than way too much. The patient is, they are not mentioning like the patient's urine output has completely stopped. Not like that. But yeah, it is putting some stress in the kidney. It could be because of dehydration. It could be because of multiple factors. We don't know what. But yeah, this disease can cause kidney can cause acute kidney injury as well. So all of the patient will not have this kind of picture. Some can have, some might not have. Okay. Main features are these 4. Okay, which will be there in case of G6PD von Gierke's disorder as well. But in case of von Gierke, there was a catchy point of recurrent hypoglycemia. Over here, there is nothing like that. Okay. What other disorder is associated with the deranged fructose metabolism? That is also been covered. Tell me. From the question, what you are understanding. What other disorder is associated with the deranged fructose metabolism? Deranged fructose metabolism. What other disorder is associated with the deranged fructose metabolism?
Benign fructosuria.
Yes, benign fructosuria. Why? They are asking for, first try to break the question. The questions are framed in such a way just to confuse you. You already know the answer, but the question is confusing. They are asking for what other disorder. So they are trying to know which other disease is there. Fine. Is associated with the deranged fructose metabolism. That means what? The fructose metabolism is not happening properly. Other than hereditary fructose intolerance, what is the other disease? जहाँ पे fructose metabolism नहीं हो रहा है. That is as simple as that they are trying to ask you. Everybody is fine with Hindi, right? If I am speaking in between. Okay. So, what other disorder is associated with the deranged fructose metabolism? In case of benign fructosuria as well, fructose is not getting metabolized, but the patient is asymptomatic. They did not say that the patient will present with same symptom. The question was tricky, that what other disorder can also present with a deranged or defective fructose metabolism. Because over there also the fructose is not getting metabolized. Whatever fructose you are taking, it is coming out as it is. Got it? That is benign fructosuria. Okay. So up to this much, this 3 topic has been covered. Any doubts till this much? No. Okay, fine. So last is remaining is the galactosemia or the galactosuria. This is what you already have known. These 3 were something which you did not have much of an idea. The last one you have little bit more idea, better idea at least. Okay, let's see. The patient profile is given over here. A patient whose name is, let's say, X, whosoever it is. 6 months age, female patient. Chief complaint is poor feeding. The patient is not taking food properly. Vomiting is there, diarrhea is there, and lethargy since birth. The patient is weak. Okay. Now, history of the present illness, symptoms started shortly after birth. So it means it's something is with the congenital disorder. Okay. Mother reported cloudy urine with a strong odor, which is commonly seen in case of galactosuria. Okay. We don't know yet. Okay. Developmental delay is noted. Why developmental delay? If your body is not getting proper nutrition, obviously there will be developmental delay. What is the main source of galactose in case of a baby? Breast milk. Breast milk contains more of lactose than galactose. Okay. So baby is only taking breast milk only. So it is rich in galactose, and none of these galactose are getting metabolized. From where the baby will get nutrition? That is why the developmental delay is also there. Okay. Now baby appears listless and poor muscle tone. Now the exact muscle tone is not absent. The muscle tone is poor. Means baby will move his hand or foot, but not much. Basically the baby is less active. Normally the babies are more active. They should be active, but in this case the baby is less active. Got it? Now, recurrent episodes of jaundice and hepatomegaly. Over here also, you are again getting hepatomegaly, again getting jaundice. So, kind of similar presentation, but little difference is there. That is over here, you are talking about more about the growth development. Okay. Why? Because in other cases, you are getting fructose after getting a certain age. Over there, the milk and all, whichever lactose and galactose are getting metabolized properly. So the baby is growing up to a certain age. Then the symptoms are precipitating. Over here, by birth only, the symptom is precipitating. Why? Baby cannot utilize the galactose only, which is there in the milk. Okay, that's all. So this is how you have to differentiate from the cases. These are not bookish terms that I am telling you to help in differentiation. These are so that you understand how to differentiate. Because if you read in the books, things will be more or less similar only. That can give you a little bit of confusion. Yeah, if you study in detail, obviously your confusion will be fine. But what my purpose is, so that you can identify the cases properly. Let's say in an exam, the similar kind of question is given and they are asking you to differentiate. And that time when you are studying everything together, you might have a little bit of confusion, like which one is what, everything sounds so similar. So that is why if they are mentioning about recurrent one, it is most likely von Gierke. If it is not recurrent after fruit juice also, it is not getting corrected, most likely because of fructose intolerance. As soon as after taking birth, patient is, they are talking about developmental delay, baby is not responding much, baby is lethargic, weak. There is we say it at like milestones are not getting developed properly. Milestones means the baby growth. The more the age progresses, the baby's working capacity. पहले जैसे baby को अगर देखोगे तो ऐसे he's just there in the lap. Later on they keep on moving, start rolling, crawling, all these things. So these things will take more time. If the baby should have been crawling by 6 months of age or 12 months of age, the baby will start crawling after 1.5 years. Like that. That is a delayed developmental milestone. Okay. So those things will be there. Now clinical examination, the weight is below 10th percentile. It's a different terminology that they are using over here. What we use in case of community medicine, I'm just giving you a rough idea so that you understand what they are trying to say. Let's take this is a graph. Okay, every baby should have a growth phase like this. Okay, and this is the lower limit. Let's say this is the 50 percentile and this is the 95 percentile. Okay, so if the baby is growing less than that, that means the baby's developmental milestones are much more lowered. And 10 percentile means this baby is growing and this level, very low. The growth is very low because the baby is not getting nutrition properly. Okay, so this is rough idea. When you will go to community medicine, they will teach you better. What is 10th percentile, what is 50 percentile. 50 percentile means if you calculate among 100 children, the growth is in the middle. If you calculate among 100 children, if that is 95 percentile means the baby is growing better than 94 other babies. Okay, and in this case the baby is performing bad 90 as compared to 90 other babies. That bad the baby's condition is. 10th percentile means he is good, but he is better than 9 babies. That is what is 10th percentile. Okay, if he is 90th percentile means he is doing better than 89 other babies. Okay, in simple word, that is what is the percentile means. Now over here liver is palpable. What is liver is palpable means liver is enlarged, then only it is being palpable, otherwise you cannot palpate the liver. Normally you cannot palpate the liver. So liver is palpable means liver is enlarged, and that is written as well, enlarged 4 cm below the costal margin. Costal margin means this is the rib. Under the rib there is the liver, but you cannot normally palpate the liver. But if the liver is enlarged, as soon as you palpate, you can feel that hardness, that hard liver, you can feel it, palpate it. Okay. Jaundice is also present, similar presentation, hepatomegaly there, jaundice there, hypotonia, that is a reduced muscle tone. Hypotonia is muscle tones are less. Okay. Now lab findings are what? Reducing sugar substance is positive, but glucose dipstick is negative. This is one key word. What is that? We are talking about what? Galactose. Okay. Now when you are doing the you reducing sugar substance, let's say you have done the Benedict test. Okay, what will be the finding of the Benedict test in this patient?
Positive.
Positive. Why? Because galactose is coming in the urine and it's a reducing sugar, that's a galactose. It's giving positive test. But if I do a dipstick test, what will be the finding? Why? You told negative, but why dipstick test will be negative? What is dipstick test? I always try. What is dipstick test? One stick which is already coated with a particular chemical to identify the particular substance. Now dipsticks are particularly identifying glucose, not galactose. So the chemical particle that is there in the dipstick that can detect only glucose. So you are getting Benedict test positive and dipstick negative. That means the reducing substance that you are getting in the urine, it's not glucose. That you can rule out. It can be fructose, it can be galactose, it can be anything else, but not glucose at least. That is was the indication. The reducing substance where you are doing, that is a positive. But when you are doing the dipstick, it is negative. That is ruling out glucosuria. At least not glucose, it is not glucose. It could be something, anything else, but not glucose. That is what you are ruling out. Now blood work, serum bilirubin is elevated. Obviously, liver में सब कुछ deposit हो रहा है तो liver bilirubin तो बढ़ेगा ही. Liver enzymes AST, ALT, everything are mildly elevated, not extremely. In case of hemolytic jaundice, in case of obstructive jaundice, they usually get highly elevated. Over here it is mildly elevated. So some pathology is there because of same deposition. Okay, I'll again come to the same thing. Galactose 1 phosphate uridyl transferase low activity. This is not GALT, this will be GAL1 put. Okay, the enzyme which is there, whoever has written this, there is a typing error. So GALT is the gene which is defective and the enzyme is the GAL1 PUT enzyme. Okay, galactokine is normal. Okay, these are not necessary for now. Okay, now, so we can understand that it's a case of galactosuria and galactosemia. Why? In the circulation the galactose is not getting metabolized and the galactose is circulating in the blood as it is. So galactosemia means when the galactose is circulating in the blood as it is, that is galactosemia. Coming in the urine, unchanged, galactosuria. Okay, fine. So underlying biochemical defect in classical galactosemia. Biochemical defect, we already got it. These are the biochemical defects. One are the liver enzymes which will be little slightly raised. This AST, ALT will be raised. These are the glucose enzymes. If you are checking for the GAL1 put enzyme, you can get the enzymatic defect. Okay, and GALT gene defective should be there in both the parents. This is also a recessive disorder. If both the parents are having defective gene, then only the baby will have a defective gene, and then only the GAL1 put enzyme will be defective and the symptoms will precipitate. Okay. Now, what causes the presence of reducing substance in the urine despite the negative glucose test? Again, read the question and try to understand. What causes the presence? Second number question. Substance in urine despite the negative glucose test. Yeah. They are basically trying to ask you regarding this dipstick test and the Benedict test. Okay, when you are checking for the reducing substance, it is present, but as soon as you are checking for the negative glucose test, it is negative. That is a dipstick test, because the dipstick is specific for glucose. Okay, that's all. So that is how they can frame the question in a twisted form, just to confuse you. In last form also I have given you one question, here also I am giving you one question. In all of these questions, they are asking simple thing but in a twisted form. So if you are a little bit confused in the exam hall, you can just miss it, the questions which you already know the answer. Okay, so whenever somebody is asking you some twisted question, just keep your mind quiet, try to understand, reread the question twice, thrice, then you can answer it. Okay, it's not necessary all the time that they are asking difficult questions only. Okay, now why does the child present with hepatomegaly and jaundice? Because of similar conversion. Over there, glucose, this was fructose 1-phosphate, over here there is a galactose 1-phosphate. Galactose 1-phosphate is defective, which is getting accumulated in the liver and causing the hepatomegaly. What other enzymatic deficiencies can cause the galactosuria and how are they distinguished? There are many other enzymes. The most important enzyme that you have to know is the GAL1 put only. Other than that, no need to remember. Okay, fine. Remember that much only, that GAL1 put enzyme is defective, because of which you can get this. Okay. Now, what are the long-term complications of untreated classical galactosemia? If you are not treating the galactosemia, what will happen? Obviously, the baby will have failure to thrive. Failure to thrive means in pediatric language we call is the baby is not growing properly. In medical language, in the question paper, it might be asked like the baby is having failure to thrive. Now you will not be thinking like, what is failure to thrive? What ka matlab kya hai? If you don't understand the meaning of failure to thrive, you will not be able to understand what they are actually trying to tell you. The main meaning of failure to thrive is the baby is not developing properly. Baby is not growing in an adequate way how the baby would have grown. Okay, that is in medical term we call as failure to thrive. Okay. So this and hepatomegaly will be that the jaundice will increase. If this same galactose 1-phosphate goes to brain, that can cause intellectual delay, developmental delay of the intellect. Okay, because behind everything, whatever our body is functioning, behind that we need energy. If you are not giving energy or glucose supplementation to the tissues, they cannot function properly. The main reason behind is it. Okay, so in this patient, the patient cannot metabolize the galactose, and from the very childhood, the babies are depending on milk only. And if you don't stop it, don't give the alternate fooding to them, so that from there they can get the nutrition, from there they can get the energy, and their development becomes normal, they will have all these complications. Okay, fine. So these are the long-term complication, means it can lead to hepatic failure, can lead to liver cirrhosis, the patient can get poor intellectual development, the patient can get poor milestone development, the patient can have failure to thrive. These are the long-term complications if you don't treat it. Over here, the patient will not have that many repeated episodes of hypoglycemia, might not have. Might have, might not have. Everybody will not have, because the babies are feeding every 2 hourly. Okay, so every 2 hourly they are getting the foods. 2 hourly or 4 hourly they are getting the foods. So they are getting little bit of energy from there. So hypoglycemia might not be that common. Okay, but this presentation will be there. Okay, the presentation will be, this liver will be palpable, this jaundice like picture will be there. Normally after birth jaundice can be there in a baby. That is physiological jaundice. When you will study in physiology, you will get to know the physiological jaundice can be there. But after 7 days it should subside. If it is persisting after 7 days also, continuously it is persisting, something is wrong. It could be hepatic reason, it could be biliary reason, it could be obstruction, it could be these kind of things. Whatever it is, you have to rule out then. But that is not physiological at least. Fine. Now, what is the cornerstone of treatment? The cornerstone of treatment is you have to identify the case first and then give alternative diet. Stop breastfeeding, stop milk-based foods and give soy-based diet. You have to give them so that the baby can get more nutrition. For now, this much knowledge is necessary, nothing more than that. Basically, what you are giving is milk-based food tolerate करना, avoid करना है, avoid करके soy-based fruit देना है उनको, so that they can get alternative nutrition source. Fine. And what is the importance of the newborn screening for galactosemia? Now, there is a certain thing called screening. Screening means what? As soon as a baby is taking birth, it is very difficult for a doctor to identify which baby is having disease, which baby is not. Most of the babies are normal only, looking normal, and you cannot identify this by seeing at the patient immediately. So what you can do is you take the patient's urine sample and go for a Benedict test. Check for the reducing sugar. If it is negative, means nothing is wrong there. So that is a screening test. You are doing one test and ruling out all the diseases that can be there. Now let's say your screening test is coming positive, means Benedict test is coming positive. Now you know certain reducing sugar is present. Now your particular test should be there, like you are doing pepper chromatography after that, to rule out whether it's a fructose, glucose, galactose, maltose, whatever is there. So this is how you go for the diagnosis. So that is what is important of the screening in case of a newborn. Whenever the patient is taking birth, check the urine sample, go for reducing sugar only. If the reducing sugar is absent, then baby is normally fine. Nothing is coming out in the urine, right? Every metabolism is happening. Everything is fine, going fine only. That's all. Okay, so these are the questions of answers over here which is given. This is the enzyme is written wrong over here. This will be GAL1-PUT for enzyme which is defective. Accumulation of galactose-1 phosphate is giving you the hepatocellular damage and going for the hepatomegaly. Okay, now over here these are enzyme deficiencies, all has been explained. Fine. Immediate elimination of the galactose from the diet by avoiding the lactose containing food like breast milk and dairy products. These you have to avoid, and soy based food you can give, or some formula feeds the babies are taking, right? The NAN 1, NAN 2 that you can see, the powder containers the babies are having. So there are certain containers which are galactose free. It will be written over there like this does not contain galactose, that you can give. Those kind of milk products you can give which does not contain galactose only, because the more you give the galactose to the baby, the more galactose-1 phosphate will be accumulating in the liver and it will precipitate the disease more and more. Fine, got it? Any doubts from the four of the topics? No, right? Everybody is fine?